Welcome back to the Make a Baby podcast. I'm Carolina Sotomayor, your Reiki womb healer and podcast host, and I'm here with Victoria Wigley, and we're talking about all things embryos. Victoria is an embryologist, and we've never had an embryologist on the podcast. So I'm really excited to talk to you specifically about anything you have to share about embryos. A lot of women in my audience choose to do IVF and choose to make embryos for many different reasons. And some use them right away, some freeze them. And I just we've never had a discussion, but I have interviewed people where they were REIs and they discussed the quality or they had a grading system of embryos. So, and I always found that interesting, but I didn't really understand it. So thank you so much for being here. Where are you at in the world?
So I am based in just south of London, so a place called Surrey, which is sort of southeast of England. And yeah, as I say, I'm an embryologist. I've been one for nearly 18 years now, which
Wow.
it's a long old time. And actually, when you think about how long IVF has been going, Louise Brown, who's the first IVF baby, only she's 47, I think. So actually, when you break it down like that, you think IVF really hasn't been around for that long,
No,
in comparison to most other medicines and sort of medical fields. So yeah, it is a wonderful career, very high stress, which we can talk about
I bet.
later, which is something that often patients don't quite realize that side of things as well, for how much we're invested in our patients and the embryos and like the guardians of these little mini beings. We do take it incredibly personally and seriously. So yeah, love being able to talk to all different people about the area, about what we do, and how patients can really get themselves through their cycles.
How did you choose to become this? Because this is when I came across you, I was like, wait a minute, that's a thing. What makes sense, it's a thing. But, if you're not exposed to that title or nobody really talks about it, even in the IVF process, the IVF clinics, they're not mentioning the word embryologist. Can you
So,
explain or tell us a story of what led you to this career?
yeah, no, of course. Firstly, you are absolutely right. No one talks about us. We're like behind the lab door. We're actually doing the real magic. Yeah.
Right.
Patients will write cards in to say thank you to all the doctors, all the nurses, all the wonderful receptionists. You've made my baby. And we're like, hello. So yes, you're right. We are forgotten about and not known much about. So yes, so my journey, I started off doing human genetics at UCL. So that was my degree. Didn't really know where I wanted to go with that afterwards. So I decided to do an MSc, which was just in the area that I found the most interesting. So the MSc was prenatal genetics and fetal medicine. So already it was in the area of before the babies are created, so to speak. And actually, I didn't want to go into anything sciencey particularly. I was actually wanted to be a manager, which I honestly, now I think about it, it's the worst part of what my job ever was. So yeah, that was silly. And so actually, it was my professor of the masters, and she said every year there were a couple of people who she thought would make good embryologists, and she said, "Oh, this year, it's you." And I thought at the time that was a real compliment. And it's only now that I know what makes a good embryologist. She wasn't necessarily being particularly complimentary. It was the kind of people who are very, very particular, a bit OCD, very, very in tune with fine detail and a little bit anal, perhaps. And that's what she obviously picked out in me. But she was right, and I'm still to this day good friends with her. So yeah, I have a lot to thank for Professor Joyce Harper.
So break down the role of an embryologist, because I think that's really vital. You mentioned you're the magic behind and often not spoken about. What exactly do you do? Just a little bit of background about me. I used to work in pharmaceutical manufacturing, and I'm kind of curious about
Okay.
this. I had made animal vaccines and I had made human medicine. And I had to follow United States, the FDA, the Food and Drug Administration. They have guidelines for standards in which things had to be done, all the way down to the ink on our standard operating procedure and batch records. Everything was a controlled environment. I'm very curious, just because I'm a curious cat. I imagine with embryos, you have a governing body or a certain standard of things that you have to follow that are similar that are related to the UK. Can you also talk
Yeah.
about that? Just because 'cause I'm super curious about that just because of my background.
Yeah, no, of course. And it sounds very, very similar to what you were just describing. So in the UK, we are governed by the HFEA, who are sort of our overall governing body who inspect clinics. They ensure that obviously all the rules and regulations are being adhered to, and we have to report all of our data to them as well. So they collect up all the data about UK treatments. Um, and then when it comes to the actual lab side, it is very, very, very protocol driven. You can't deviate. There are standard operating procedures, our SOPs that we have everything you do from setting up the culture dishes the day before, through to how you go about doing egg collections, what order of events you do things in, what media you use here and there, all the way through to, the end stages of embryo transfer and embryo freezing. Everything is very, very strictly adhered to. We monitor practitioner results, so they are constantly being assessed in the lab. So if anything were to go slightly awry, you take that person back, you strip back, right down to the basics again, just because it's so important what we do that we have to have a really, really tight monitoring and regulation on it.
When I first started my pharmaceutical career, I'm no longer doing that. I've been out of the industry for over 5 years, but I was told there's no room for error, and that sounds exactly what is in your laboratories. And given you had mentioned, like, the level of stress, and I can imagine any regulated industry that where you're doing with human health is extremely stressful. So I can imagine when you know the effort in which it takes to get the sperm and to get the egg and the retrieval and if an error is made or just this pure just knowing like what you are carrying in your juices or whatever you're using, I can imagine I can only empathize, like, that is the highest stress. Can you talk about that?
Yeah, no, of course. So you're absolutely right. It's as much as we have our SOPs and we have all of the ways that we know we're supposed to be handling the dishes, the way we're supposed to be, following certain procedures, we are humans and human error can happen. But it's something that you have on you because thank goodness in my 18 years, I've never dropped a dish, but it's happened. And, it's something that you can't help sometimes, if your lab shoe gets slightly caught as you're walking or anything like that, it can happen. But it means you are on high alert the entire time you're in the lab to make sure that you just don't want anything to happen because you know that that what you're dealing with is so valuable. It could be the patient's last cycle. It could be, that they've got very low ovarian reserve. And if they go again, they might not retrieve something. Or the sperm might be, in some cases we use posthumous sperm. And then you think, oh my goodness, like this is really important because there isn't necessarily going to be a second shot at this. So that can really take its toll. And I think there is more and more understanding now, especially because we are seeing, especially in the UK, quite a shortage of embryologists at the moment. Lots of the people that were obviously, if we go back to sort of talking about that first time IVF, started, obviously all of those embryologists are at the point of retirement and all the rest of it. Then you've got the next tier down who are potentially going off and doing slightly different things like I'm doing now, which we can go into later about what I can offer people now. And then our training scheme changed. So we're getting less people coming in. So you've got people all at the top that are going off, less people coming in. And that then just adds to the stress because not only are you're really stressed day in, day out anyway, but there might be fewer of you in the lab. And so your workload is incredibly increased. So yeah, there are lots of areas that are very stressful, but you have to just hold on to that, try and look after yourself and your well-being. Um, and then when people bring in their babies, that just makes it all so worthwhile, so worthwhile. One of my closest friends, her little boy Dylan, was grown in my lab before I even knew her, and It just makes it so special. He calls me Auntie Vix because we're always going to have a connection. People say I've seen little baby grows that have on the top, my first babysitter was an embryologist. And it's just when you think I've been picking you up and down in my pipette and now you're a baby, it's incredible. Like that and that will stress will go away when that happens.
So what is wild to me is I had a private coaching client and healing client, and I walked her through preconception to deciding if she wanted to do another round because they had no more embryos left, so they were gonna have to start all over again. So when we did it, and she ended up I sent Reiki to her through her entire procedure, and then to her embryo. While it was like, I'm like, "How many do we have?" "We have 3." "Okay, I'm sending." And we just, like, put a little picture on my altar, and I would just focus and send them. So it's so special to think of the connection. So the spiritual side, because I've never had this conversation with anyone. So you're science-based, but when I think about it, there's these things called soul contracts, some people believe or not. Those contracts are our mother, our father, our brother, sister, and then people who we marry, people who we break up with, people we may have conflict with, etc., having major life events with. This makes me think of like the soul contracts you have with these babies and these mothers and these parents of like, and I've never thought about that. So then you have a soul contract and you're helping bring this in. So it makes me think of like the soul contracts you would have to have. And this is so magical to think of like the care that you have. It's not science. Like I think sometimes science gets a bad rap, or like there is this non-emotional side to the clinic or the IVF part.
Yeah.
And
I think,
really
yeah,
there's
embryology is,
highly it's a lot of care. There's a lot of emotion, a lot
yeah.
of love behind what you're doing.
Absolutely. And I think most, like you say, most science careers are, that they are very behind closed doors. You're given a sample, you have to, analyze the sample, you give the sample results to the doctor, and then the doctor is patient facing. Embryology is one of the few areas where actually we're doing the analysis, but then we're getting that human interaction as well. So we're doing the lab work, but we're patient facing. And I think that's what makes the connection so much more. So we always think of our babies are the ones that we did the embryo transfer for. Now, that's not necessarily the case because obviously so much goes into it before. But I still remember the name of the little boy who was my first ever embryo transfer where they got pregnant. He was a little boy called Bo. Don't know any other details about him other than that he lives in a town called in Portsmouth. And this would have been 2006, no, 2008. So yeah, he'll be turning 18 this year. And I think, wow, like that's nuts. Yeah, he will always will remember that little boy. Never got to meet him, but yeah, he was my first ever IVF baby that I claimed as mine.
I love that so much. Can you walk us through the process? Like I got pregnant. There was nothing wrong with me. I got pregnant after a Reiki session, and that's what led me here to this work. But
Mhm,
I love to work with women who are going through IUI, IVF, or
mhm.
any whatever their fertility plan is. But can you walk us through the process of how you get an embryo? I feel like there's a lot of lack of information, or people maybe not have resources to that. Could you explain
Yeah.
what is the process to a woman that gets an embryo to even implant or transfer?
Yeah, no, of course. So there's two sides, obviously the male side and the female side. So if I start off with the female side, because obviously their process starts earlier. So their first probably about 2 weeks, we won't be involved in the lab. That's when they're seeing the doctors and the nurses, they're taking their stimulation medication, and they're being monitored to see how well their follicles are growing. When the doctor's happy that the follicles have reached a certain size and the hormone levels are all looking good, that's when they get triggered ready for egg collection. So this is where we then come in. So the female patient will be taken into the theatre room, usually under sedation, and then the doctor will go in under ultrasound guidance with a very fine needle and will puncture the follicles. They'll then draw that fluid out of the follicle. into a little tube, and then we will take that little tube and pour it into a petri dish, look under the microscope, and we're hunting for those eggs. So usually we'd expect one egg per a good sized follicle. So we will go through all of the fluid that the doctor's collecting. And then when we found all our eggs, we'll then put them into a culture dish, and then they go into the incubator. So now they're in a solution of media, which is mimicking the fallopian tube. So it's as if they've been ovulated. We've got all the right nutrients and environment to keep them happy. The incubator is all set as well for a certain temperature and pH to try and make everything as body-like as possible. So that's the female side done for that part. Simultaneously, we have, if the partner is producing fresh on the day, we'll get a sample from him, and then we will prepare that sample. So by that, what I mean is if we just talk, now this is why I'm getting at gory details. Sorry, I talk a lot about sperm.
I think it's important. Um, we have a lot of members of the LGBTQ plus community that also buy sperm.
Yeah,
And
absolutely. So,
yeah, this is really important because also, like, we had a couple that was on the podcast who bought sperm, and then they were talking about, like, if they wanna have siblings and buying enough sperm to ensure, like, for a second full sibling. I think this is
yeah,
so important to talk about sperm. People need to say the word sperm more
yeah.
in this context of
Oh,
fertility
definitely.
is to get we just need to get
Yeah.
more comfortable. So
No,
talk about the
definitely.
sperm.
I will. I make a great dinner party guest when I start talking about sperm. So yeah, so then if you imagine a raw ejaculate, so that would never meet the egg. So this is often a misconception with people. They think that we just take the raw ejaculates and then that's what we use to fertilize. It's not, because if you imagine the raw ejaculate is what we call the semen part. So it's got all of the fluid and mixture with the sperm within it. That part will always stay in the vagina. The actual sperm will be able to swim up the cervix, leaving behind all the gloop, and swim up through the cervix, through the uterus, and then up to the fallopian tubes where they'll then hopefully meet the egg. So that is the pathway that happens in a normal conception. In the lab, we need to mimic that. So we need to work a way of getting the sperm out of the semen, and also to try and make sure we get the best sperm there. A lot of sperm in a normal male sample, we only expect 4% of the sperm to be morphologically normal. And that's good. We go, congratulations, you've got a good sperm sample, if only 4% are normal. So we
Wait,
don't,
wait, back
yeah,
that truck
yeah,
up.
no,
Wait, stop it. Wait a minute.
yeah,
Wait, you just say it again because no, I I'm all about breaking down the patriarchy. Like, but men always like, "Oh, I got good swimmers." So you're saying the normal male, only 4% of their sperm is good enough to procreate with
yeah.
on the
And
average
that's actually
male.
not even the amount that can capable of fertilizing or going on. This is the amount that look morphologically normal.
Oh,
So you have,
wow.
yeah, so
That's
you
even
have,
different.
yeah, so it is a lot. They produce some level of million, so 15 million-ish is about normal.
Okay.
About half of those just don't move. And then of the other half that do move, only about 4% of them look normal. In my mind,
Okay.
I think the women produce one egg at a time each cycle, because they go, right, this is our natural selection, and we've got a good one we're releasing out. And then with the men, there is a lot of sperm, but a lot of sperm that unfortunately aren't very useful.
Is
No, we have our ways of doing it. So we use a solution often and a centrifuge to block the immotile and grossly abnormal ones. We block them at the top of the tube, and then there's a solution with beads in, so the good sperm can swim through it.
oh, wow.
And then we take just the pellet at the bottom, wash it around, spin it down again. So yeah, we have our ways. There are also
Wow.
a bit more advancing ways of doing it, where you can sort of get him to swim across a membrane, and then that helps do the selection. Of
Since we're talking about sperm, can I ask a few questions about sperm?
course, you can.
So, on reference of my knowledge is just interviewing fabulous people women like yourself across different modalities and professions. Can you talk about so I spoke to she was a Chinese medicine doctor, and she was talking about how important the quality of the sperm is, like you're talking right now about the physical ones, like the ones that are even viable to use or even to consider. And then she was just talking about how the quality of the male sperm is so important to the embryo, because that can really choose, like it can really impact whether an embryo can implant or not, or the health of the embryo. And I think a big misconception that I learned in that conversation was, it's not all on the woman. It is sperm health matters a great deal. And
Yeah.
also sperm health is the quickest thing in a fertility journey. Like if a couple wanted to work for 90 days, they could really improve sperm health if they worked with their doctors and understood what needed to improve, like not smoking, changing underwear, like changing diet, like really for 90 days can really improve the sperm health. Are you able to, so with that knowledge, like I was blown away. But with sperm health, I guess I need to land the plane and ask you a question is, can you tell the health of a sperm by just looking at it? Like, could you tell from a male sample, like what they need to do as an embryologist before they start like the egg retrieval process? Like, can you also look at that as well?
Yeah, no, definitely. And absolutely everything you would say then is correct. So it was always the case historically that a man would have a semen analysis done, basic semen analysis where we look at, as I described before, the count, the motility, how well they're swimming in a straight direction, and then the morphology. If that all met normal standards, anything that was bad or went wrong was put down to the woman. And the woman had her biological clock ticking. Men could do whatever they wanted at whatever age and be absolutely fine with their fertility. Now we are finally realizing that that is just not true. So what we do now is not on all patients, but if patients are having a history of the implantation failures or recurrent miscarriage or things like that, yes, there is the element of the egg health, which is still very important. But we are now also looking at the sperm health. So what we are trying to do is to send those patients, send the sperm off to get tested for what's called DNA fragmentation levels. Now, this is what I think the lady you spoke to was alluding to. Men, those DNA fragmentation levels can be very, very significantly influenced by external parameters and variables. So things like smoking, poor lifestyle, raised testicular temperatures, if men use a lot of saunas or hot baths, things like that. All of this can actually impact on the DNA fragmentation levels. Now, the benefit for men is that every 3 months, their cycle of sperm, regenerates. It's not that they have everything set out and then it will be a static number that they're then stuck with for the rest of their life. They can, with changes to lifestyle and most importantly, taking high level antioxidant supplements, especially if their diet isn't as good, that can reverse this high level of DNA fragmentation. Obviously, now we know more about that. In an ideal world, I would get all our patients to come in and the men to get checked first of all, because like you say, it's the easiest thing to focus on. Having said that, if their partner is 40 years old, you've got to weigh up. Is it worth focusing on absolutely optimizing the male sperm for 3 months, the detriment of delaying her treatment for 3 months? So you have to weigh it up on a case by case basis. And that's the part I love doing with my patients one-on-one, because we can look at their history. We can look at whether, making the changes, yes, definitely carry on. But is it worth making the changes, then reassessing the DNA fragmentation levels and all things like that? Or whether we just then move straight to what your second part of your question was, which was how can we as embryologists know what sperm is good? And unfortunately, we will never conclusively know that the sperm. So with IVF, we have nothing to do with it. We mix the sperm and the eggs together and we leave them to it. With ICSI, where we inject the sperm directly into the egg, we as embryologists pick the sperm. Now, that's where we do the best we can to make sure we're picking the best morphologically appearing sperm, but we can't see what is actually the integrity within that sperm. So we look at, under high magnification, we look at all of the structure on the sperm, how the sperm's moving, and all things like that. If a patient has known high levels of DNA fragmentation, we can sometimes do an increased selection method, which is where we either do something called IMSI, where we really rank up the magnification to look at much more detail, especially in the sperm head. Or we can do something called PIXI. Sorry, this is a whole other language. But
No,
PIXI,
I think it's so important exposure to these words because I have questions when you're done. Keep
yeah.
going.
Oh, okay. So PIXI is where it's also a enhanced method of selection, but PIXI uses a solution that contains like a hyaluronic acid. So I know we normally talk about that on our skin, but this is, if we put the sperm into that solution, if the sperm binds, then it means they've got the correct receptors in their head, so they're functionally mature, and that can indicate that that sperm has a better chance of success with fertilization and subsequent embryo growth. So they're the things that we try and do for patients if we know they've got a high DNA fragmentation level. If they don't, and this is their first cycle, and there's nothing to indicate that there's an issue, we would just do conventional ICSI. So yeah, that's how we go about trying to optimize the sperm. But there is unfortunately, no conclusive way of saying that sperm that I'm picking is a good one. But yeah,
Wow. I'm so glad you brought up ICSI. Is that how you say it? Is it an
yeah, ICSI.
acronym? Is it IC?
Yeah, so intracytoplasmic sperm injection. So it's basically you're injecting the sperm into the cytoplasm, which is all the in the middle of the cell.
Wow, this is really random, but I love me
Yeah.
some TikTok, and there is a lady who does where I've heard ICSI before, but she owns a very large or she has a breeding farm for horses, and
Okay.
she talks about ICSI with her horses. So I'm like, "Wait a minute, I know that word." So the creator is called Katie Van Slyke, and she
Mm,
breeds show horses, like, for different events and, like, Western riding in Tennessee. So, like, she has, like, 4,000,000 followers. Everyone's
wow.
invested in her horse breeding farm. So
Yeah.
she used I've heard that word before. I'm like, "Wait a minute." So,
Yeah.
like yeah. So I'm like, "This is so important." Wow. Okay, so once you make the embryos, this
Mhm.
is, like, the mystery part that I am so curious about.
Yeah.
So say you go through that process and what happens next? Like, what's the next sequence of events?
Okay. So if we go back to that first day where
Yeah.
the egg collection has happened, the sperm preparation, whether it was fresh, frozen, partner, donor, whatever the sperm was, that's been prepared. Then we do the insemination in the afternoon. So as I mentioned, there's two different ways. Is the IVF where we just put the prepared sperm sample into the dish and let the fertilization happen naturally. Or we do ICSI where we inject the sperm in. Then we leave it overnight, and then the next morning we come in and we check for fertilization. Now, this is the part that I think most patients find the scariest because they are sitting at home waiting for that phone call to say how many of your eggs have fertilized. Um, and it's scary for them. It's really scary. So we try and be as empathetic, especially if it's not been a good outcome of fertilization. But usually, and this is also another misconception, people often think that, especially with ICSI, when we're physically putting a sperm in, they assume that they're all going to fertilize. So we'll often have patients who get maybe 7 or 8 out of 10 that are fertilized, which is really, really good. And they'll say, oh, but what happened to the other two? Because the assumption is that they're all going to fertilize, which just isn't correct. So yeah, it's that's usually for the patients, that's the trickiest part. And then once we know how many are fertilized, that's when we culture them into the lab. So more and more now, people are having the dishes put into the time lapse. So with the time lapse, and this is where you see all the wonderful videos on social media with embryos developing. With time lapse, what happens is you've got a camera sitting above the dish. And it takes a photo every 5 minutes. So it means you can see exactly what's happening as a video roll. So we can see, is that normal development? Is there anything going on that isn't supposed to happen? What are the timings of events? all things like that now give us so much more information about the embryos and which ones the best ones are.
Wow. Do you do the embryos, do you ever implant embryos right away, or can they be frozen? Is that still a thing?
Yeah, no, so it's a complete case by case basis. So we still do fresh transfers, which we try if we can get them to grow to day 5, which is the blastocyst stage. Only about 50% of the fertilized eggs will make it to that stage, but that's completely normal again. That's what we're expecting to see because we don't expect all the eggs that we collect to have the ability to go
Oh,
on and form blastocysts.
that also mimics natural conception.
Yeah,
Like,
exactly.
because not all fertilized eggs will, I mean, but I think that a lot of people, when there's so much effort out, like, there's and it's so invasive with the whole process of a retrieval and doctor's appointments, people have high expectations. But when I'm listening to you, I'm like, that makes sense where you were giving the example of out of 10, they're expecting all of them to fertilize. But what I'm also hearing is like, but also on a normal basis, I hate to use the word normal, but in stereotypical, when a woman is trying to conceive, not every month is the egg going to eventually over time, most cases, like, which is a matter of time with me and my nervous system regulating itself in support, is like some eggs are not going to stick, or they're gonna pass.
Not at all. So the best thing I say to patients, so if I get private patients that come and they've not had IVF before, they're my perfect ones because, and this is something you can tell your patients as well. In a normal cycle, so a cycle where we are not doing IVF, they're having a normal cycle where their body will ovulate. Whether they're trying to conceive or not makes no difference. Just if we focus just on what happens in a normal cycle, we get a cohort of eggs that start to grow in the ovaries. They get about halfway up in their development. And then through some method of natural selection, we have no idea what the body knows, what the body can pick up on. Only one of those gains dominancy and carries on growing. That egg then ovulates out. Those remaining ones, they don't get reused for another cycle. They then die off. And then the next month, the whole new batch start. Now, in IVF, that same batch will start to grow. But because we're then pumping the patients with so many hormones, we force as many of those to keep going up to the point of ovulation. And that's where we then come in and we can retrieve those eggs. Now, what I say to my patients is, say, for instance, they collected 10 eggs. What I will say to the patients is, in a normal cycle, your body would have only let one of those eggs even have the chance to meet sperm. And like you mentioned, even when they ovulate the egg, the sperm might not get there in time. Even if it creates an embryo, the embryo might not be good enough to implant. So much down the line also affects it. Of the eggs we collect, I'd say to people, just remember that, yes, it's great if we collect as many eggs as we can, but tell yourself that those drop-offs that happen at each stage during the cycle, so from the number of eggs collected to the number that fertilized, from the number that fertilized to the ones that form blastocyst, and then from the ones that form blastocyst to the ones that can or can't achieve a pregnancy, all of that is a drop off, but it's a drop off because we're using eggs that wouldn't have ever even had the light of day to go on and meet a sperm. And I think if you can get that mindset into people, it is so important because then they go into it with a different approach and attitude.
Oh my goodness. I could talk to you forever. I do have a couple more questions.
No, of course.
When do people choose the gender? Sometimes if there's a gender of the embryo, can you tell that? At what stage can you tell that before you transfer? Can you do that or no?
So actually in the UK, we're not allowed to. It's not
Okay.
legal in the UK. Yeah. So I know in America it is, and quite a few European countries as well it is. But in the UK, we're not allowed to. The way that it can get found out is by doing what's called a biopsy. So when the embryo forms a blastocyst, so the point where it's day 5 or day 6, we can take a small cohort of cells out. The embryo at that point has around 100 cells. So we can take a very small cohort of cells out. And then that's usually done if we're checking for the genetics. So a lot of your patients might talk about PGTA, where we're looking and screening for anything that's abnormal with the number of chromosomes. So that's things like Down syndrome, where we know that the baby would have 3 copies of chromosome 21 instead of the normal 2 copies. So when we're doing genetic screening, we're looking at the different number of chromosomes that we've got. And ideally, we want 2 pairs of each of the set. Now, you can also at that stage look for the X and Y chromosomes, which can then reveal the gender. So in the UK, the genetics lab will know that information. They don't disclose it. They just disclose all the other chromosomes to say if the embryo is genetically normal. But obviously, if you are in a country that allows it, at that point, you can have it on the report. But because they will also look at the number of normal chromosomes anyway, the numbers will go down. If you specifically say you wanted a girl, you would have your number of blastocysts that were able to be biopsied. Then of that, there would be another breakdown of the ones that are viable versus unviable in terms of the numbers. And then of the ones that are euploid, which is where they've got a normal number of chromosomes, you can then see the difference in the sexes. So it's not easy and straightforward by any means, and it's certainly not a guarantee. People think, oh, I'm healthy, I'm fertile, I'm going to just do a round to be able to pick my gender. But there is a lot that goes into it before you get to
I
that
bet
stage.
you that's such a controversial topic on to allow it, not to allow it. And that is not something I am well versed in. So we'll leave that one alone. Can you talk about the process and the risk, pros and cons of freezing your embryos for later?
Yeah. So is that freezing embryos or freezing eggs? Because it is the egg freezing that
Embryos.
people do for embryos. Okay. So
Yeah.
for embryo freezing, people tend to do when they are with a partner who they want to have children with, but for whatever reason, they can't have a transfer at this stage. So it might be that perhaps there's a
Maybe
big
they
life
made
event that's
more.
happening, or yeah, they potentially want to, if they know maybe their ovarian reserve is getting lower, they want to bank some embryos at that stage. Because then if you have one baby from it, obviously you're then looking for another 2 years down the line, and then maybe doing another round wouldn't be successful because of that extra aging. So people can often do that, so they bank more embryos to be able to sort of safeguard having siblings in the future. Sometimes people, if they're going through like a cancer treatment or something, people can, so it's called fertility preservation. So they are just making sure that any chemotherapy or anything that they might have isn't going to affect the embryos. I would always say to patients that embryo freezing is much better than egg freezing for a number of different reasons, but people often think egg freezing is a guarantee to then being able to use them in the future. And unfortunately, it's not only the survival of the eggs much less than embryos, but also you don't know what the potential of those eggs are. And until we grow them to the embryo stage, we don't know how they're going to be. And the risk is people will freeze their eggs at maybe 35, 36 because they haven't got a partner, or they're not ready to have children yet, or whatever the reasons are. And then they come back maybe 40, 41, and they try and use those eggs. And even if we get good embryos, we can't guarantee more than about a 50% chance of a pregnancy. And that's once we've got through all the other hurdles before that.
Right.
And then unfortunately, then sometimes if that cycle doesn't work, they're then in a position where their fresh eggs aren't as good as they were 5 years ago. So I will always say to people that yes, egg freezing is okay to do, and yes, it's good, but don't use it as your guarantee. Use it as your backup, and still try with your fresh first when you are ready, and have the eggs as a backup. Don't think of them as being your guarantee to have a
Yeah.
baby.
I think that I've seen on pop culture and in TV shows are like freezing your eggs is your guaranteed hall pass. Like an insurance. It really isn't.
Yeah.
And it's really expensive, and it's not an insurance. Like I think a celebrity on a TV show recently offered his 18-year-old daughter to freeze her eggs. And everything you just explained, there's so much that can go wrong. There was a lady who has a podcast called Quiet the Clock, and she came on and talked about her process that she went to through freezing her eggs and her journey of freezing her eggs, and then she had not met her partner, and then going on to meet her partner and all the hurdles that she had to go through with her fertility. And I think it's just a common misconception that people think is a normal story that's told and is true and is not. So it is really important to know that um that it is not a guarantee. Just like a lot of people rush into IVF and they think I'm going to do IVF now because nothing else works, and it's a guarantee. And a lot of people walk away through not have had, not the right doctor or the right clinic, the right pairing or support team, and walk away without a baby. That is very possible. And I don't think enough people
Yeah.
are told throughout the fertility process of like, nothing's guaranteed, nothing's 100%. And I
Yeah.
think that that just needs to be spoken, screamed from the mountaintops of like, nothing's 100%. And I think when people are
Absolutely.
exerting so much energy and money, there is that expectation, whether they're told explicitly or just this, usually when you spend money, you leave with something. Like you may be leaving without a baby.
Yeah. Yeah. Which is the most brutal part when
The
you
brutal
say you've
part.
spent
Yeah,
everything and yeah, it's not a guarantee. And I think it's really a big, big part of it is that there is such a lack of fertility education out there.
that's why we
We
people like
in
you. Thank
schools,
you.
yeah, in schools and stuff, you think the amount of time we get taught how not to get pregnant, which yes is great. Obviously, we want to reduce unplanned teenage pregnancies. That's one side, but we spend all our lives trying not to get pregnant and then think when the time's right, it will just happen. And it's because, one
Yes,
in six couples will need some form of intervention around fertility, and it's just not spoken about. One in four pregnancies end in miscarriage. There is so much that is because it's still a taboo subject because we're not talking about it. There is so much out there that people just don't understand before they start the journey. And it makes it so much harder. And then because people don't talk to each other, they think they're so alone and they're the only one going through it. And it's just not the
absolutely.
case at all. So support groups and stuff like you were mentioning, that's where they really
Yeah.
come into their own. You get people feeling actually there are other people just down the road from me and it's all happening to them too.
Yes, your neighbors, like, so much more people go through miscarriage or fertility treatments, and last night I led my first in-person women's circle, and a lady mentioned she was unfamiliar with this particular name of this drug called Clomid, and
Mhm.
everyone in the room like, "Oh, yeah, this is what you need to know about," and then she, like, lit up, and she's like, "What?" And, they're like, "Yeah, we can this is what to expect," and she's like, "Nobody told me that," and I was like, "Girl, we got you." And it was
Oh,
totally changed her face. You could see her body shift out of tension and fear to like, "Oh, wait, this is like
yeah.
I can do this." I want to thank you for coming. You've been such a joy to have you here. I have had goosebumps this entire conversation. I always love interviewing women that are doing important things in the world that serve other women. It is just my jam. Before I let you go, can you please let us know where we can find you on the internet and how we could possibly work with you or how women could find more information from you?
Yeah, no, of course. So my little company now that I'm sort of not as much in the lab anymore, I've set up my company called All About Embryology. So I obviously have two folds to this business where one is just education. It's out on social media, telling patients, what certain things mean, explaining all the terminology, doing little videos. So you can see videos that I've put together from inside the lab and that really help sometimes patients visualize what's actually happening rather than being spoken to about it. So that's really good for people going through the journey anyway. And then I also do individual one-on-one consultations with patients. And the reason I started doing this was exactly actually, if we go right back to the start of the conversation, when you
Right.
said that the embryology part people don't know about. And as much as the doctors are wonderful in what they do, actually, their knowledge is sometimes a little bit lacking in the lab, or they don't pick up on the fine details of things that we will see. So I love trying to bridge that gap. So one blessing that's come out of COVID is that we are all used to now having consultations and things online. So when I set up the business, I thought, you know what, I can do this. I thought it was going to be UK based to start with. Now I have consultations with people all around the world, America, Bali, New Zealand. So what patients can do is either they're my first timers, so I can do all of that nitty gritty explanation, really make sure they go into it with their eyes open. They're not being missold add-ons that they don't need and all things like that. I can just be there to explain it all and support them through it, get them to ask the right questions. And even if they're sort of choosing a clinic at this point, I can get them to sort of work out how to compare stats and the different ins and outs of what to look for. So they're
Yeah,
one of my
you
groups of
are
patients.
the magic that was missing and for so many couples.
Do you know, it's such a wonderful thing when I hear patients, like one patient the other day, she was just getting off the call and she just burst into tears. And I was like, are you okay? And she just went, I just feel like I can do this now. I've got you by my side. Oh, it's going from when I first set the business up to not really realizing actually the support side of things. They can
It
email
is
me at any time, and yeah,
it's
rather than kind of
everything.
going on the internet.
It is, so I mentioned in my first circle last night in person, and when I left there, my husband goes, "Are you okay?" And I was like, I've never like, this is like I almost said I was never been happier, but, like, it was a top 10 moment for me.
Yeah,
In my like and I was like, got married, yay, had my kid, launched my podcast, yay, held my first in-person womb healing circle, done
yeah,
them online, but it was just different.
yeah,
The transformation and the energetic connection you have in providing someone support in their fertility journey on something that many of us expect to be innate and easy,
yeah.
um, there's nothing like it. It is so fulfilling. Thank you so much for being here. Can you tell us where we can find you on the internet?
Yeah, so with obviously I've mentioned the handle for the social media is at All About Embryology,
Oh, okay,
and then
great.
my website is www.allaboutembryology, all as one word, at .co.uk. So that's when you can kind
Okay,
of book on for the consultations. People
great.
send me all their lab records and things I can review in advance and things like that. So ones that have been kind of going through it all before. So all of that information is on the website as well.
Perfect. We will link it in the show notes. Thank you so much for being here,
Thank you
Victoria.
so
And
much.
for all of those who are listening, don't forget to join our Make a Baby community, which is free on the school platform. We are going live and having our after hours chat and support every Thursday. And we can't wait to see you in our community. Until next time, let the Reiki flow.